Thank you, Kumran, for giving me opportunity this IC, and thank you, AIOC, for this conference. Just a general thing. Let us leave this talk and let us leave anything prescription. Why do we want to document? So, as you would have heard the earlier talks, we really want to see how things are before we operate, because we are not running the CSSG ourselves, we are relying on others. So basically, as a surgeon, when you get instruments in OT, you want to make sure that things are okay, they have been properly sterilized. So you ask your sister to do a check, or like you would like to see yourself the indicators have changed or something, right? So one purpose of documentation is to get things in an order, so you document that. Second most important thing would be a medico legal reason. God forbid if there is an outbreak or if there's a issue, then you need to have all your records in order for investigating agency, which could be from the government side. So that's a medico legal requirement. And the other requirement for you would be for yourself to recall. So you have some suspicion, you want to recall back and trace how things are working for you. So a very important thing is traceability. So these are the principles you record. How you record, I believe, is left to everyone. It's just a principle that, okay, if you have a problem, so you should be able to recall an instrument from your OT back to CSSD, to the process, to the autoclave used, and also, if you are having a multiple OT setup, like for us, we have 7 OTs. So one autoclave cycle, whatever instruments have been done, might be in multiple OTs. So you should be able to recall and trace back each and everything. So as long as this is attained by the documents what you keep, rest all is fine. So I'll just show you some sample formats. And these are just to give indication to do things. You could have your own formats which you are using and they're perfectly fine. The problem here is that somewhere in the middle, if one of these things is missing, you will never be able to trace and recall. So that's where the lacuna I feel would be there in some hospitals. But basic record is always kept. That's, I believe, is the first part of training for everyone. Other thing, important thing is, what should be the documentation? Like for us, when we started, make NABH process, and sir was there. So 2009 or 10, we felt that our documentation is not so much proper, and the recall process was a weak point. And NABH has a very stringent recall policy. So we started modifying documents, and then with every passing day, like inputs, do better, and we want to improve ourselves. In that improvement, the documents goes on increasing and increasing. So from a phase where the documentation was probably okay but not adequate, you went to a phase of over documentation, and now for last 2-3 years we are actually trying to reduce the documentation. So over documentation does not ensure result. And as far as CSSG goes, my personal thing is, if your CSSG staff will also change, and there'll be multiple staff for us. If you simplify things to a 5th grade level, they work. You complicate things with our knowledge, make them medical kind, they don't work. So to simplify that, what we have done is we have SOP, which is meant step by step how a machine is to be run. And the entire CSSG process, from washing, cleaning, storage, everything is in not more than 20 points. It's like 1 or 2 pages stuck there. So whosoever is on duty has to follow from 1, 2, 3, 4, 5. You don't deviate. In case they have any issue, they will have to inform someone. So it's a very standard point-wise SOP which anyone can follow. Do this, press button, very simple. So earlier we had made an SOP which would be a book of 30 pages. Not required, condensed everything, displayed. So that SOP will simply also have what indicator they are going to use, when it has to be used, how to use. An autoclave, the 20 cycles or 12 cycles we discussed, very clearly mentioned autoclave machine, which cycle to be used for what load we are doing. So for our requirement, everything is just set button. Anyone can run. Even if you go there, you can read and you can follow the instructions there. And the most important thing is, for all the activities, we have a responsibility defined. So there's one person who's going to take charge for our biological indicators, water culture, OT cultures, and he will maintain what time it was done, how it was done. And if he's not there, he will ensure that someone else will do, or it is adjusted a day here and there. So with that responsibility, we don't have any issue. So our initial documentation while doing all these tests has been reduced. And the monitoring or audit is done by the HIC committee, OT in charge. So we have a doctor, so everyone will keep track. So when I go to OT, I do check for my OT. Whenever our OT in charge will go, they'll check. And HIC committee is always looking at the documents. So the most important thing and something would be biological indicator. Dr. Kurman showed everything to you. So for us, we use both biological indicator for steam and ETO. They come in different color. This is ETO and that is it. So once a week, we do a biological indicator. And every process, we document that biological indicator has been registered on, then it goes to lab. And this is the kind of report you'll get. So this is a report for our autoclave. Can I have a pointer if you have? So this is a report which we'll get, and it's a negative report. Same what Kumran shows. And this we do for ETO and we do for autoclave. Bovidic test, every day before starting autoclave. And this is the maintenance what Kumran was again saying. You can see the sticker here, the strip here, and this is the machine parameter. So our machine would have an automated printout here. So you'll get with every minute when the cycle is proceeding, all the temperature parameters and everything is here. And it has a self-leak test. So you can run a self-leak test, and we run a Bovidic once morning in this machine. So we run one machine, we have a backup machine, but this will be our standard machine, which it's huge enough for our load. And these results are maintained in register. So tomorrow, if anyone wants, we have a, let's say, a break of end off. If you want to check, this register will be verified. You will get entire record in this register that we have run Bovidic every day before the autoclave has run. So we operate all day, so we run it once every day, right? So now this register could be anything yours. So the only thing is we want to have a record that, okay, whenever the sterilization activity has taken place, the Bovidic was run. It could be twice a week also based on your load or your hospital. Similarly, we do a PCD, like Helix one, we have a different one. So PCD also is run in every load, and then it is maintained in the register. So this is our CSSG measure. This is only going to take this, and other parameters will be mentioned. So this is where you can go back and check for each and every cycle what were the parameters, and wherever your machine or ETO machine is giving a printout, please prefer printout. That record is actually good to maintain and troubleshoot. So this is our autoclave register. So in autoclave register, very important, what was the load of the day? You may run it multiple times. What are the load details? What contents were in that? Which set number? Whether it was linen set 1 or 2 or 3. And then you will also have your indicators. And here you can see a class 5 indicator. Kumran showed you a big thing. That was a different company. And then this is our autoclave register record for that cycle. And this was a load. So you can see what all, like biopsy set 01 was there, probing set 01, orbit set 01. So all the sets are numbered, which set was in which load. And now these sets obviously will be stored. And when they are used, in the OT register, corresponding entry will be there. So when I operate a case in patient file, let's say I have done a biopsy. So my patient file will mention biopsy set 01, will have the indicator from that set in the OT register. So it will be there. So I can trace back from my file, my OT register, back to autoclave register, back to CSSG. So everything will link up. And usually we do numbers. You can use alphabets. You can use a mixture of alphabet number, whichever way it works for you. Or if you already have a system, just see it's matching. Same thing for ETO. We maintain an ETO record, what cycle and everything. But since ETO has a longer shelf life, we keep it for 6 months. Going back usually is a little not so much required, and we don't do so much of ETO load. So this is how the instruments would be stored after autoclave. And this is an issue register, what I verbally told you. So every instrument which is stored here can be traced back to the load and can be traced back to which OT it was issued and which patient we have used that. So we can go forth and back, and that is the purpose of documentation. If you can ensure that, that's the best documentation we can have. Same thing with ETO, where it was issued, what was issued, which patient it was used. Air culture, we do once a month. We do active air sampling as well as settle plate method. So settle plate, typically all corners of OT and center. So if you see here, this is the settle plate report. Now, this is for OT1 and then OT2 and OT3, so on. So you'll get this report, this first page. And a similar report we'll get for air sampling. So these are all 7 OTs what we have. And you can see that all 7 culture report is there, no growth. Now, all these reports, how do we maintain is that copy of report will go to OT in charge. If you see below, from the lab, straight away one copy will go to OT in charge, one copy will go to HIC secretary. So that's a clinician. So immediately a copy will come. In case any of the report is not telling if there is any growth, then immediate it has to be a phone call, not even a report sent to anyone. Any positive culture, they will immediately report to everyone on phone from the lab so that you can immediately take corrective action. Report might still come a bit late. So preliminary report, the moment they see, they raise the flag. These reports are there. All these copies are maintained at 2 places for us, in OT as well as HIC. So there, each of all these reports periodically is there, and we always have this check there that, okay, the water culture was due, the air culture was due, has it happened, and what is the report? For water culture, we are little aggressive. So from our instrument wash area, we do every weekly. For the scrub area, or what we use for scrubbing, is monthly, and potable water anyways is 3 monthly. So again, a similar report, we just document from which tap it was collected, and the report there that, okay, the culture is sterile. So this again we maintain in the same way. And OT culture, the swab we take monthly. Many people do frequently, much less than that. In fact, we always have debate. I don't know, they can update. In Tamil Nadu, it is requirement to do it every fortnight. Any high volume institute, you might even do weekly. But this is our protocol. With our load, once a month we take swabs. And if you see, again, the report will have all the OT 1 to 7, and then, microscope or spotlight for my OT, or, a GA machine, or all equipment which we use inside. A swab is taken from everything. And this report again will come. So the take home message for, okay, so is that simplify the documentation, because people who are going to do should be able to do repeatedly. Many a time it's just like us, like our OT notes. We always crib writing 20 times, 30 times, why we are writing so much. Same thing. So if you simplify the operating process, don't keep too much at the CSSG level, it works fine. Otherwise, if we put too many parameters, the record never gets complete. And when you are going to audit, you are yourself going to say that, it's 50% complete. Give it in a way, it's simple to use, record everything, and monitor. Monitoring is important. So for us, we do it at 2-3 ends, from clinical side and from the OT in charge side. Audit yourself and see if anything is getting amiss, definitely sort it out. And in audit, again, repeating it probably for the 5th time, we just check that we can come from the CSSG to the OT and also go back, which is a recall process back and forth. Thank you.
Thank you, Dr. Gagan, for this wonderful talk. And we started early and are finishing early, but we still have 10 more minutes. I'll be happy to take questions. So you can speak in the mic, sir.
The boarding takes daily before the starting the autoclave for daily. Is it a costly affair for the small units?
You can switch it on, sir.
Its cost is 180 rupees, and
The cost of the Bovidic strip, you mean?
No, bovidic test. Tubing. You told about the tubing for every cycle before the every day's first cycle is the bovidic test of the cycle. The tube one.
No, the tube is the helix test.
Helix test.
Helix PCD test. There's a process challenge device. The helix tube comes in 2 materials. One's a silicon and one's a SS, and the cost varies from brand to brand.
So do we need to take sample from the sterilizer at any point of time? I have read it somewhere that we should once in a month take the sample even from the sterilizer, the inner and the outer coat. Do we need to do that?
No, it is basically we don't advocate regular microbiological surveillance.
Right.
But if there is a endophthalmitis or a TAS, so it's part of the incident reporting and trying to find the root cause analysis. That time we do. Or if there is a cluster endophthalmitis, it's a part of the investigation.
Thank you. Good morning. Thank you for a wonderful class. I have a couple of doubts actually. For the microbiological surveillance that we do monthly swabs, the fungal culture that you send, the microbiology does the culture for, do they give the report within a span of 3 days, or is it the culture for 1 month? Fungal, when I had sent it for a swab, the college, the private college had suggested they keep it for 1 month because fungus grows very slowly. But the protocol says 3 days will be sufficient. So what do you suggest?
It depends on the type of organism you are expecting, right? Generally, we do for aerobic and anaerobic bacteria,
Yes.
and very rarely for moles, right? So, if there is the initial growth, and then it's a decision of the microbiology team to see to maintain for 6 or 7 days and then report. Or if they have a doubt in the type of organism that grows, then they will wait for some more time. So, or if there is a fungal endophthalmitis, you have a suspicion of that, you can specifically ask for fungal growth. That they will take at least 3 to 4 weeks to report.
Also, one thing that I observed, especially this class 1 indicator, that the tape that we have, the amount of blackness, like the darker, it becomes very dark when it is placed in a type B autoclave, and it is very light blackish when it is placed in a normal pressure cooker type for the linen. So does it really matter?
No, that is,
for the linen, sir.
no, the color doesn't matter. Whether you like dark black or light black, it doesn't matter.
It doesn't matter.
Right? What matters is that it has gone through that process. That's what. So that's the reason why we encourage to use type 5 or type 6 integrators.
Types. So my doubt is actually there's a type B autoclave for the instruments, hollow instruments, but it's a very low capacity thing. So to place linen in that on a daily basis for case to case, it becomes very difficult and practically it is not possible. So, but then in the pressure cooker type, the autoclave, it's not really satisfactory. I mean, some loads are fine and some loads are not great. So any other suggestions?
No, if you have both Class B autoclave as well as a vertical autoclave, you can use the vertical autoclave for linen and direct instruments.
Okay.
You can also change the cycle in the Class B autoclave. So generally that's what we do. So we keep the instrument and phaco handpieces separately. First load. Second load is the cloths if at all we need. So most often we use the disposable items.
Okay. Sir, and the phaco handpiece is 121, right? Not the 134.
You have to check your manufacturer's recommendation. So most of the manufacturer recommend the regular cycle.
See, the Class B autoclave, there is a constant removal of moisture from the chamber.
Correct.
So your the Class 1 remains black, but whereas in a pressure cooker, the water is there inside, it gets washed away and becomes more light grey.
Yeah.
So that could be the probable scientific explanation.
So one more last thought. What is this activewear sampling that Dr. Gagan has suggested? I mean, we use a settle plate, but activewear sampling. Oh.
Next session.
I have a question regarding tabletop B-class autoclaves and the horizontal B-class autoclaves. Do they compare? How do they compare? Is it all right to use a tabletop B-class?
The principle is the same.
Yes.
The
volume is less.
It's only the size.
Yes.
So in the tabletop, everything is compact. Depends on the size, say 23 liters or 40 liters or 22 liters. Depends on the size of your organization and the number of surgeries you do.
That's right.
So if you want that in a bigger scale, you have this long horizontal cylinder where it's based on the number of bins you can keep. You can have 2 bin horizontal autoclave or 3 bin, depends on the beyond 4 bins, it's industrial type.
In a small setup, B-class should do that. Tabletop B-class.
No, so it's not the setup that matters. Number of surgeries you do,
Exactly.
a number of reusable or disposable items you use, and how frequently use. That is more important.
So we can go ahead and use the tabletop B-class.
Why not?
And one
There
more
are
question.
institutions who have 10 tabletop autoclaves and regularly use it, even large volume hospitals.
One more question I have. Like you are doing biological indicators as well as the steam integrators, the class 5. So you start the procedure, you find this integrator is fine, the test is successful. Then you send it your biological indicator for incubation. It comes after 24 hours and the test becomes negative. What do you do about it?
So 100% of the or most of the time, this situation does not happen. It's more of a hypothetical situation. If your a class 5 integrator is gone through, then your biological indicator will also as we go through. So this is what is being reported in the literature, and I have never faced a situation where this situation has happened.
Last month I faced the situation.
No, it
then
might be the defective indicator itself. Because the staff can damage the indicators while sticking or putting into the along with a sharp instrument. So in that case, you have to recheck the same indicator. I mean the different indicator, and if it fails again, you need to contact the vendor and recalibrate your cycle time.
So if the class 5 integrator test is successful, you can definitely go ahead with your surgery.
Yeah, definitely.
So nowadays you have a latest device where the biological indicator can be read in 10 minutes. So the Yes, it costs around 60,000 rupees. So it's a fluorescent dye included inside the biological indicator. You just put this indicator into the machine, it reads it in 10 minutes.
Company's name is? 3M.
3M
Okay.
has.
3M has.
There is one Indian company, Medister is also dealing with that. Medicis.
Okay. Thank you.
So thank you. I think I will call the session an end. I thank all my co-speakers to be a part of this wonderful.
So generally that's what we do. So we keep the instrument and phaco handpieces separately. First load. Second load is the cloths if at all we need.
Second
So
load
most
is-
often we use the disposable items.
Okay. Sir, and the phaco handpiece is 121, right? Not the 134.
You have to check your manufacturer's
Manufacturer.
recommendation. So most of the manufacturer recommend the regular cycle.
In a class A autoclave, there is a constant removal of moisture from the
Correct, sir.
So your the class 1 remains black, but whereas in a pressure cooker, the water is there inside,
Yes.
it gets washed away and
And-
becomes more light gray.
Yeah.
So that could be the probable scientific explanation.
So one more last thought. What is this active air sampling that Dr. Gagan has suggested? I mean, we use a settle plate, but active air sampling. Oh.
Next session.
I have a question regarding tabletop P-class autoclaves and the horizontal P-class autoclaves. Do they compare? How do they compare? Is it all right to use the tabletop B-class?
The principle is the same.
Yes.
The
volume is less.
It's only the size.
Yes.
So in the tabletop, everything is compact. Depends on the size, say 23 liters or 40 liters or 22 liters. Depends on the size of your organization and the number of surgeries you do.
That's right.
So if you want that in a bigger scale, you have this long horizontal cylinder where it's based on the number of bins you can keep. You can have 2 bin horizontal autoclave or 3 bin, depends on the,
A
beyond
small-
4 bins,
yes.
it's industrial type.
In a small setup, B-class should do that. Tabletop B-class.
No, so it's not the setup that matters. Number of surgeries you do,
Yeah, exactly.
a number of reusable or disposable items you use, and how frequently used. That is more important.
So we can go ahead and use the tabletop
Oh, yes,
B-class.
why not?
And one
There
more
are
question.
institutions who have 10 tabletop autoclaves and regularly use it, even large volume hospitals.
One more question I have. Like you're doing biological indicators as well as the steam integrators, the class 5. So you start the procedure, you find this integrator is fine, the test is successful. Then you send it your biological indicator for an incubation. It comes after 24 hours and the test becomes negative. What do you do about it?
So 100% of the or most of the time, this situation does not happen. It's more of a hypothetical situation. If your a class 5 integrator is gone through, then your biological indicator will also as we go through. So this is what is being reported in the literature, and I have never faced a situation where this situation has happened.
Last month I faced the situation.
No, it
then
might be the defective indicator itself. Because the staff can damage the indicators while sticking or putting into the along with a sharp instrument. So in that case, you have to recheck the same indicator. I mean the different indicator, and if it fails again, you need to contact the vendor and recalibrate your cycle time.
So if the class 5 integrator test is successful, you can definitely go ahead with your surgery.
Yeah, definitely.
So nowadays you have a latest device where the biological indicator can be read in 10 minutes. So yes, it costs around 60,000 rupees. So it's a fluorescent dye included inside the biological indicator. You just put this indicator into the machine, it reads it in 10 minutes.